Very good afternoon. I will talk about how to do a good flexible ureteroscope. Right. So first, talk about indication. According to the IU guideline on RIRS, actually less than 2 centimeters in diameter, I think is the first choice for flexible. But sometimes for in the kidney, in the upper ureteral stone, sometimes is more than 2 centimeters. But PCA cannot do it. Sometimes is control indications you can do. I think this is two indications. What about the control indications? According to the IU guidelines on flexible RIRS, actually, I think acute infection you cannot do. Sometimes patient fever, patient pain, maybe with infection. You must be careful. And then patient cannot do general and regional anesthesia. You cannot do. Sometimes for PCNA, you can do local anesthesia. But I remember you cannot do RIS for local. You do local, impossible, impossible, because this patient you can flown blood, ureteric maybe really pain. You cannot do it. Yeah, low way. Yeah. Let's talk about preoperative image. According to IU guidelines, I think the low dose CT is a must. It's a general education. You must do it before you do flexible ureteroscope. And sometimes you must check detailed collection system anatomy. You can do it. You can do this contrast, CTU or IVU. Sometimes you will do local stone. You must check IP angle. You must know, and you talk before operation. You must talk about with your patient. Oh, this IP angle is too less than 30 and 20 degree. Maybe it's very difficult to do it. Flexible cannot go in. You must talk about sometimes flexible is failure. You must change a larger mini percent, super mini, and bala. You must do it sometimes. Remember. On the other hand, a low dose CT, you can check stone hardness. Sometimes you must remember for younger urologists, you started to do flexible. You must remember stone heart is very important. Sometimes this stone is less than 600, maybe HU, maybe it's really easy for you. But sometimes this HU is more than 1,000. You must be careful. Maybe it take a long time for you. And then I always think stone diameter as an indication for flexible is not too good. Not so good. I think it's warning is best, and the boarding area is the second. For this less than 2 centimeters, such as this stone waist is 2 centimeters, long is 0.5 centimeters, and another is 1.80 centimeters. You see, it's totally different. You see, this guys is same height, but different weight. This is really weight. This is the same height. You see, this is 1.9 centimeters, and this one is 0.7 centimeters, and the larger is 2. You see, this take a different operation time. For this may be very fast for you, and so this side maybe is taken long, maybe 2 times longer time. You must be careful. And then talk about antibiotic. According to IU guideline and IU jaw insertion for flexible management of renal stones is low infection, such as urine culture is negative, white blood cells is elective, it's okay. Before operation, you in one dose you see that. This is everything is okay. But sometimes urine culture positive, and then you use the antibiotics, the urine culture to negative. Or how many days is negative high level evidence? How many people use antibiotics urine culture from positive to negative? How many people? One, two, three. Oh, not too much. 7, not too much. Actually, according to the AU joint consensus on RIRS, you see is 72% panelist son. You only used 4 or 7 days antibiotic CC lab. Actually, in our department, our center, almost is 7 days, and then do it. So do flexible for you, Albert. The same.
Are you repeating a new urine culture?
Or
no.
No?
Do you repeat a new urine culture after the treatment or?
No urine culture. No urine culture. It's use 7 days and they do operation. No. Yeah.
When there's a positive MSU culture, it's important to know whether the patient is symptomatic or asymptomatic. It's 2 different beasts.
Yeah. This true.
If it's symptomatic, so much more careful.
Yeah.
And sometimes it's maybe too soon. If the patient has sepsis and positive, 7 days, so that is too soon. So it depends on each case.
Right. And another is really confused for everybody. For Chinese urologist, maybe sometimes the patient is positive urine analysis, but urine culture is negative. Sometimes the urine culture is negative, and then the urine analysis is white blood cell is too much. How to do? How to do, schema for you?
Patient is asymptomatic.
Yeah.
Then maybe a prophylactic antibiotic. You can begin, and
Yeah.
this suppression you can go further.
Maybe you use you wear your Windows.
Yes, exactly. Prophylactic.
Windows is enough.
Exactly. And then you may go further.
How many people agree, Professor Campbell's opinion? You only 2.
Antibiotic?
Actually, in our department, for this situation, I always use 3 days antibiotics, then do operation.
Then perform a study, 3 days, 1 dose, and see.
Perfect. Professor Zeng is do this clinical trial.
Let's see.
This group is only 1 dose. Another is 3 days, more than 3 days, and compare this favor, post-operative favor, and blah blah blah. It's okay, maybe. Now, what about your outcome? 怎么样？
It's a very interesting question because not all patients with an infected stone produce a positive urine culture. That's another confusing element of it.
Yeah.
So it depends how big your trial sample size is. You only need 1 or 2 patients to skew the whole trial. So it's a difficult question. You need the proper trial to answer.
Yeah.
And you need a multi-center.
Yeah, maybe for this clinical trial, you can randomize this patient 2 armies. 2 armies. One is 1 dose. One is more than 3 days. Maybe compare.
And then you do stone culture.
Yeah.
And then you see
Yeah.
how many positive urine culture has the same bacteria,
Mm.
how many negative MSU
Mm.
actually has bacteria in the stomach.
Perfect.
And I had sepsis on the operation room. My question is, how can we predict stone who there is infection and they don't with the negative analysis and negative culture? There is some tools to predict this kind of stone.
Yes, you're right. Sometimes urine culture is negative. Sometimes stone culture is positive. Yeah, this. So sometimes this randomized. Randomized is okay. Sometimes for this windows maybe urine culture is positive, and 3 days maybe the randomized. I think is okay. Get a microphone.
Because my center, I mean, I don't send urine analysis. I just send urine culture. So I just want to inquire, what do you define as positive urine? Side X-rays?
So that's another confounding thing is that most people rely on positive urine culture more than 10 to the power of 5 per mil, but and many people don't do a dipstick on the day. And some people do a dipstick on the day, and then for some people it's MSU positive, or rather MSU negative, and then dipstick positive on the day. Then what do? You know, you cancel the patient, or you continue, you give 3 days antibiotics, things like that. So there are many confounding factors as the flow.
Yes.
So, and what's your practice then? Do you do dipstick on the day of surgery?
If the patient, we definitely do urine cultures, and if they are positive, we will treat until they're negative before we do the operation.
No.
So it's slightly different from the so but we are like ultra cautious, but we think it's worth it because we don't know the patient taking the risk of severe complications. But everyone in the world has a slightly different practice.
Yeah.
There's no right, there's no wrong.
Yeah.
You just have to decide what you want to do for low practice, and you need to be able to justify.
Thanks.
Yeah, my
Please.
practice.
Please.
My practice from my surgery of PCNL or RIRS. From the day I see the patient, usually a week or 2 weeks before, I already start him or her with a low dose of antibiotics, prophylaxis antibiotics. Maybe a nitrofurantoin of 100 milligrams BID alt before the surgery. Yes. Yes. For cephalosporins. For me, because regardless of in my practice, there's no guidelines or no evidence base. Okay, but for me, it fits to my patients. Okay, so because there's no literally there's no evidence right now. Yeah, there's some. You only give antibiotics on the day prior to surgery. Okay, but it fits my patient well. So far, I have no very limited cases of sepsis for that my practice. I think we already talked that before in the one in the percutaneous convention, percon, I think in India.
Yes, understand.
The microbiologists are getting more and more powerful. They're trying to reduce the number of the amount of antibiotics you can give. You know.
Yeah.
So they are trying to dissuade us from giving prolonged courses of antibiotics before operation.
Okay, continue. Must continue. Must continue. What about and you say thrombotic syrup? Everybody must know flexible is a very low bleeding risk procedure. So no need to stop thrombotic syrup. No need. But sometimes you do it maybe little bleeding. This is okay. No need to stop. No need to stop. And just now, this before flexible, you need to put a DJ stand and load. Actually, according to the guideline, no need. But sometimes is you cannot put exercise exercise. You can do it. It's not. And sometimes you do flexible procedures. You must do stethoscope. This is very important. Sometimes you go in, you must see blood. Sometimes you can some tumor, some another diseases. And the safety guideline and the working guideline is you guideline recommend. And for simple case, I think you can don't safety guideline. You must for all case.
I agree with you. Sometimes you talk to an expert, he said that in all cases, 2 guidelines. One, very simple case, there's no obstruction. You go up, so there. Two guidelines for what? I'm asking, stay safe for safe. Only one for me now. Sometimes if I go up, the flexible is going up, I mean that is the one, neither. I know it very well. In all cases, 2 for me.
How many people for 2 guidelines? How many people? You? Anyone? You?
No guidelines.
Look at it's impossible. Actually, come back to real world. Actually, it's one enough. Some very complex case, very difficult case, I use 2 guidelines. Some this is ureteral kinking I use. Agree? 7 comment.
The ureteric sheath, access sheath, is and your scope is the guidewire. So I put the guidewire out, but when I put the access sheath out, the scope into the kidney, I take the guidewire out. I then have no guidewire.
Totally agree.
But complex case, I think it's supposed to stick straight in the
Actually, I started flexible, maybe 2025. I usually use rigid Ureteroscope to make dilation and see this ureter. But now I never do it because sometimes you do it may injure the mucosa and cause the bleeding. Oh,
when
now,
you first started, the access sheath was 12-14.
Yeah.
Now it's 11-13.
Yeah.
Small.
This is true. Okay, how to place the exercise? Sometimes I usually put the sheath under scope view and then scope view and not with X-ray. Sometimes it's fair response with X-ray and flexible see. Oh, why response? But actually, for neuro, for beginner, we must use because we sometimes for semen, for chemo, Professor chemo for you do 1,000 flexible. Maybe you can use. You cannot use X-ray. Sometimes for this pediatric and with special case, horseshoes and very ectopic sheath, kidney stone, maybe you can use. Agree?
Yes.
And sometimes how to placement of sheath under scope view. Actually, you can use simulate ureteroscope and together and the sheath together. You can see this sheath going to the orifice of ureter. Then you come back your ureteroscope. Then because you see this sheath going to the orifice of ureter because orifice of ureter is really narrow. Is this going? Is the upper is going? Must I think maybe 19% can go in. I can go in. You can try it. Sometimes sheath placement fail. you can note for this 12 and 40 sheaths, and then you can change a small size one, maybe 10 and 12 and 9.0 and 11.5 sheaths. But for this sheath, for this kind of sheath, it's only this portion 7.5 flexible, and this Olympus X2 P6 can go in. For this small size scope can. And sometimes you see the correct position of sheath is below UPJ 1 or 2 centimeters. Sometimes you can put a needle, you can put the upper, but maybe you can increase pressure. You see, this is here, this is the middle ureter is too high, as the upper ureter is below UPJ is very low. So different place and different pressure. So in the morning, Professor Genin talked about the smart irrigation pressure system. Sometimes the sheath is different, pressure is different. So this is not accurate, I think so. Okay, when you use disposable flexible ureteroscope, how many people use disposable? Now? Oh, too much. Too many. Actually, in our department, I have reusable. I have single use, half, because you always use single use, maybe increase cost. It's not too good. Sometimes for complex stones, and then I think it's short operation and small stones you cannot use. And you can use resident training. You can use sometimes for your hospital. You have reusable ureteroscope, but you have too many flexible ureteroscope operations, so it's not paid. Because you use reusable, you can come realize it again. It take maybe 2 hours or maybe 3 hours. Maybe you can use flexible. For this infection disease, multiple drug-resistant patient you can use, and the patient ask you, I'm asking you to single use. Nobody can use reusable. You can do it. How to avoid similar injury to ureter by homing laser? Sometimes not homing, by all laser. Shooting, honing laser. How to? Because I think power is really important. For upper ureter stone, for flexible, I think it's less than 10 watts. It's very important. Not use 40, 30 watts. And then fragmentation setting is very important. High zeros, no frequency, and short pass. And then small size nasal fiber, because nasal fiber is small and the working channel is 3.6 French, then irrigation is okay. And the irrigation will be less than 30 watts, 30 millimeter minutes is enough. And you must partition ratio of flexible and the sheath is less than 0.75. Important. This is small size scope and the large size sheath, really important. It's inflow outflow small is very important. And the level bone ureter police, not do it. You do it is maybe injury mucosa of ureter causes structure. And sometimes this is structure caused by this laser. I think in the luminal balloon dilation is less than 1 centimeter. Successful rate is up to 18%. Impossible. For this laser injury ureter structure, for this balloon dilator, I think 85%, not 5. I think the first choice is you must structure resection and end-to-end do it. You can do open, you can do laparoscope, you can do robot. Remember, everybody, not do balloon dilation, no fix. Outcome is too bad. Yeah, you must remember that. And how to remove in the sheath, you must endoscopy way. This is guideline recommend because according to Oliver publication, you see for 12 and 40 sheaths and the injury, ureteric injury up to 46.5% is too high. You must check it. You must check it. 这个可以放吗？ You see, you see, this is injury, ureteric injury. Maybe it's 2 degree, 2 grade, 2 grade. After you check your condition of ureter, you can put a digit stand different time. For this low injury, it's 3 days, 7 days enough. And the grade 1 is 1 to 2 weeks. And the more than grade 2, maybe 3 and 6 weeks. So it's different injury, different duration. How many people do pediatric for flexible? You do? How many people? 1, 2, 3. I think for pediatric, for flexible, I think not first choice. For example, for this pediatric little stone, maybe it's 2 centimeters. Maybe shock away. Maybe super midi I will. Because you must know this age grade of children, infants, preschool, junior. You must know ureteral length is totally different adults. It's blood volume. You see this for these children is 1 years old. Is blood volume is 19 millimeters. Must be careful. And then you must do why this children have a stone. You must check this courses. So you must do 20 hours. Sometimes is stone composition, sometimes is anatomy, and disease is some UPJU, UPJO, blah blah blah. And usually you use sheath. You must with small sheath, 9 point and 7, 11.5 sheath, and you can use those 6 tube, Olympus P6 and P7 and the Pulson small. This is 5 months. 5 months. You see, this bilateral ureter stone is here, and this is left side lobar stone. And for this, the first remove this bilateral ureter and put a digit stand and the ureter dilated, and then I do it. This is small case. I use this and for this do it. This is a post-operative CT and scan, no stone left. And the stone-free evaluation according to IU guideline, you see, 标准上的 KUB can evaluate the stone free, but CT is the most accurate. CT is the best you can do. How to remove the stone free? You can use this flexible vacuum system. Is tip bend. I can check this. Oh, no. Actually, you see, this is complete stone flow is up to 70%. I think it's good. Sometimes you can use basket, remove the lower stone to the upper pore pelvis, then you suction out. This is very important. I show this case. This case is male is 67 years old. Is solitary kidney. With this suction sheath. The suction sheath is 12 and 14 French, and I use Prof.Zeng 7.5 very small flexible single-use flexible. You saw this is 12, sheath is 12, and flexible is 7.5 French. Is between sheath and the scope is 4.5 French. So 1.5 millimeter stone you can suction out between this space. Okay. Yeah.
Is this a sheath with a steerable tip or the sheath you left in the upper ureter or in the kidney?
In the collector system, you can
Steerable tip.
It's bendable. It's bendable. But bendable is use this scope. Yeah, scope band. It's passive, not active. Not active. It's passive. But sometimes you do it. Maybe you do a bigger stone, 2 centimeters. You must here. You after operation very tired. Maybe take a long time. So I compare basket and with this suction sheath, which is better. I will do this clinical trial. Yeah. Oh, see, lost stone left. I can suction. Complication I cannot talk about because next talk Professor Campbell will talk about this. Okay. Thank you, everybody.
So next